Welcome to Sculpted and Unscripted with Dr. Azad, where we answer the most common questions about consultations, surgery, and recovery. Honest and without the script.
Hi everyone, welcome to another episode of Sculpted and Unscripted. I hope you all have a great week. We definitely had a great couple of weeks. We met a lot of great patients, good people.
Very
We
busy.
booked a lot of surgeries, so it's been great. So today I want to talk about one of the other common procedures that I do in my practice, and that is augmentation mastopexy, or breast augmentation with breast lift. Let's start with to see who are the candidates. Usually the candidates are the moms. At least in my practice, 90% of the patients that I do are moms that had multiple pregnancies, and because of that, they have not only have deflations, they also have some droopiness. You could also see that though in the massive weight loss cases. So if you have a deflation and droopiness, the augmentation alone is not going to work, because augmentation will just give you more volume. So if you have deflation and a droopiness, if you just do an augmentation, you're going to get fuller breasts that is still droopy, because the droopiness, it doesn't get corrected with breast augmentation. So in those cases that we have those two issues, well, the best would be to do a breast lift and a breast augmentation at the same time. So let's start talking about the breast lift. What is essentially breast lift does, because in that case, out of the two operation, the major contributor to that surgery is a breast lift, whereas the augmentation is just to give you upper pole fullness. So I'm going to have you take a look at the picture. I'm going to tell you exactly what breast lift does, and this is a great candidate for someone who needs a breast lift. You see, this is the bottom of the breast, I always say, which is called inframammary fold. And if you draw the line and majority of the breast falls below that line, then that's a great candidate for breast lift. In this case, you cannot do an augmentation alone, because then the implant will sit up right here, and almost everything, 90% of the breast will falls over it. So what is breast lift? What does breast lift do? It does three things. Number one is reduce the size of the areola, because over time or after pregnancy or breastfeeding, sometimes the areola gets enlarged. The adequate or aesthetic diameter of the areola should be somewhere between 42 to 45 millimeter. So we make the areola smaller, which makes it more aesthetically pleasing. The second thing is moving it up to the most projection portion of the breast, which is slightly above a centimeter or two above the inframammary fold. And then the third thing is to get rid of all this ptotic or saggy tissue, because if you leave this, everything that sags will continue to sag. So those are the three key components of the breast lift. What does the implant does? Implant based essentially. So the breast lift portion is going to make the breast tighter, is going to make it perkier, is going to make it more prettier up, and the contribution of the implant is just to give you the upper pole fullness. But one of the things that I still want to talk about, which I don't want to get too scientific, but I think is really important for the patient, is to know that the blood supply, because this is one operation that, and the plastic surgeon should pay very close attention to the blood supply of the nipple, because we're making a lot of cuts around the nipple. And the whole goal of the plastic surgeon or the surgery is when the surgery is done, the nipple areola is still viable and it survives. So one of the things I kind of drew it here, if you say this is like a breast, this is a nipple areola. The nipple area has like a 4 major blood supply, which we call it the pedicle: superior, inferior, medial, and lateral pedicle. When we do the breast lift operation, we have to cut 3 of the 4. Otherwise, we won't be able to move the nipple areola. My preference is to keep the superior pedicle. Why? Or superior medial pedicle. Why is that? Because that will give me the freedom to kind of cut all the tissue that are sagging. Remember I said, if you keep the saggy tissue there, it's still continue to sag. So there are certain cases, obviously, we'll get to that we cannot use a superior medial pedicle. We have to use a different pedicle. But most of the time, that is pretty much my go-to level. Now, if everything is okay, and I'm going to talk about that, what do you mean by everything is okay? If everything is good, 95% of the time after the surgery, the nipple will survive, and we haven't had any issues. Throughout all my practice and all the procedures I'm done, I haven't had any problem with the nipple, okay? So, but we want to make sure that we're at the 95%, which I'm going to go over it. To make the 95%, 99%, we'll, as in our practice, we'll offer you oxygen chamber treatments, which you get two treatments, one the day after surgery. The second one will be 2 days after surgery. What that does is kind of boost oxygenation to the area of the nipple areola, and like I said, it will decrease the risk of compromising the blood supply, increase and make sure the nipple areola is kind of survives, from 95 to 99. But the key is to stay at the 95%. And how do we do that? It depends on two things. One is the patient, and what I mean by that is like one of the things like smoking, and everyone knows in the office that I'm very stickler about that. So because what smoking or nicotine does is vasoconstrict the vessels, and vasoconstriction meaning like constrict the blood vessel. And we definitely don't want to do that because we are already compromising the blood supply by doing the surgery. So we want to make sure we get all the blood supply that we have. So even if you did 1 cigarette or 1 vape, I say 3 months, no smoking, no nicotine, and we do actually testing in our office to make sure that's the case. Okay. And then the other thing is like some comorbidities like diabetes, for example. Again, just because you're diabetic doesn't mean you're not a candidate. If your diabetes is under control, meaning if your hemoglobin A1C is 6 or below, then that's perfect. But if your diabetic is not under control, so you're gonna have some vascular issues, and in those cases, we want to make sure that's taken care of, and then after that you can have a surgery or some other comorbidities. The second part is obviously the surgical part, and that we want to make sure, again, you go to a surgeon. I always say like a board certified plastic surgeon with lots of experience, and the technical aspect of it, you want to make sure that's sort of pristine, okay? Now that we covered this part, there are certain instances, and I say that all the time at the consultation, that we cannot do both procedure at the same time, and we have to stage it. I know there are some surgeons that always stage the surgery. There are some surgeons that always do it at the same time. Again, I don't believe in being dogmatic in one way or another, so I cater it to the patient, and I have certain criteria myself. So I'll go over those criteria that I feel like we have to stage the surgery. Okay. So one of the things that when I look at the patient as far as a good candidate for primary augmentation mastopexy is like how much we need to mobilize the nipple areola complex. If we need to, and for me, and again, this is not like a Bible, but for me, it's like anywhere between 6 to 7 centimeter. If I notice that I have to mobilize the nipple areola more than 6 or 7 centimeter, I stage the procedure. Okay, an example of that would be, I'll show you someone. So if you are, I'm gonna have you watch this. If you see that, for example, this is a case that I'll definitely stage the surgery because you see this nipple has to go from here all the way up to here. We're talking about 8 or 10 centimeter. And if you look at it from the front view, if you have a grade 3 ptosis, meaning the nipple as the bottom of the breast, those scenarios I always say that we'll stage the surgery. We're gonna do the breast lift portion first, get everything tight, then we come back and we place the implants, because that will, in those cases, I feel like there's a huge chance of will compromise the blood supply to the nipple areola complex. Okay, so that's one scenario. The second cases that I would like to stage the surgery, if the breast is very dense and heavy. So when you have a heavy and dense breast, just to do the lift itself, because when we do the lift, we have to cut skin, we have to cut some amount of tissue and tight everything together. If you already have a very dense or heavy breast, it's already hard to get that breast tight. So imagine if you place an implant, it's even going to be 10 times harder to do that. Example of that would be someone like this person here, okay? And I have to say, usually those cases don't even need an implant. But if this person comes to the office and they say, I do want to have an implant and a lift, I would tell her, like, we have to stage the surgery because she's a young person, the very dense and heavy breasts. Just to go get a lift is already tight enough. So in those cases, we stage the surgery. Again, in this case, in this particular case, she didn't need an implant and she didn't want to have an implant. But I'm saying if someone comes in with that particular breast and they say, I want to have an implant and a lift, we'll stage the surgery. The third and fourth case is pretty much what patient expectations are. So the first two that I mentioned, technically you shouldn't do it because remember, the technical part is that you want to be at that 95%. So for the first two, you definitely don't want, I will definitely won't do it. 3 and 4 that I'm about to say is basically patient expectation. And that is like, one is if someone comes in, so the mobilization of nipple areola, let's say within the 6 centimeter, the breast is not very dense, or heavy. So those two things are great. But they have a very, very large areola. Meaning the areola is about 80 or 70% of the entire breast. In those cases, because in order for me to get around the areola, so that means that the angle of divergence now is going to be so obtuse for me to cut it out and put everything back together. So in those cases, I tell them, I'm like, hey, if you want to have an implant and a lift at the same time, we can do it, but you for sure will gonna have some pigmentations in the middle of the breast. And I know that's not aesthetically pleasing, so I show him some photos and I say, if you're okay with that, that's great. And that's something later on we can revise it after a year or two once the skin gets looser, we can come back and revise it. Or we can just do the breast lift operation, because if you don't have to put an implant again, that means I can cut more skin. I can cut around it more, and then come back and do an implant. So that will be something, but basically with their expectation. Again, example of that I'll show you here. So for example, let me go back here. Oh yeah, this case, this is what I was saying. So you see in this case, for example, you see the areola is pretty much the entire breast. So even without an implant, you see we still had to leave some pigmentation here. But she was okay with it. She was happy. But usually in these cases, I tell them you're gonna have that pigmentation here, and we can do it. We can come back and revise it, or like I say, we can put the lift first and then come back. And even if during the lift, if we still have some residual of the pigmentation, when we do the augmentation, I still cut out some skin and place the implants. The fourth case is for someone that comes in and says, you know what, I want to be lifted, but I want to have like a 400 or 500 cc implant. So that's the case that I tell them, like, these two operations, when you do a breast augmentation and a breast lift, they're constantly fighting each other, these two operations, because the breast lift is trying to get everything tighter, perkier, and up, and augmentation trying to expand it. So the goal is not to cheat on the lift, because lift is a major contributor of this operation. So I tell them, like, we want to make sure you get a maximum amount of lift that allows you to put a maximum size implant. So if they're going for that 400, 500 cc look, then again, every case is different, but I would say 90% of the time I tell them, if you want that look, we have to stage it. We got to do the breast lift first, get everything nice and tight, and then wait another 6 months for everything to stretch, and then come back and to basically do an augmentation.
Could they do like a, say, 300 cc implant and then come back and do an implant exchange?
Yeah, they can also do that too. Of course, they can do that too. They can do it with the, like exactly like Kim said, 300 cc implant and then come back and do an implant exchange. And again, and I tell them, like, don't necessarily focus on the weight on the cc, because when we're doing the breast lift operation, we literally we're downsizing the container. So even you put in a small implant, it's still gonna look perkier. I'm gonna show you another photo of that, which is, can you turn back the camera? So you see this case, unfortunately the implant, this one was deflated, a saline implant. So she had a 500 cc implant here, but she didn't like it. She wanted to be lift lift an implant exchange. So this implant here is only 250 cc. So this implant is 50% is smaller than this one, but it definitely looks much more, you can see it looks perkier, it looks much rounder, way more upper pole fullness than when she had with the 500cc. So I explained to the patient that don't necessarily focus on the volume. Having said that, if you definitely want to have that fully augmented look, we have to separate the surgery. Now, that's if you want to do like a primary augmentation mastopexy. If somebody has an implant already for like 10 or 15 years, so they're just coming in for an implant exchange and a breast lift, that's a little bit different. We have a bit more room in that, because in that case, the pectoralis muscle, the breast tissue, the skin, everything has been stretched over the past 10 or 15 years because of the implant. So we have more room to go with the same size implant or even bigger, but not in a primary breast augmentation or breast lift. Okay, I think we're out of time. So please, if you have any questions about the breast augmentation or mastopexy, give the office a call. Talk to Kim. She'll be more than happy to schedule you for a consultation. We would love to see you and hear from you. If you haven't already subscribed, please press that button. Please press the like button. Please leave a comment of what you want me to talk about, and
share it with your friends and family.
Yeah, thank you. And then we'll see you next time, okay? See you in a few weeks.
Thanks for joining us for Sculpted and Unscripted with Dr. Azad. Join us next time for another exciting episode.